Well, it is 8 o'clock and we are going to go ahead and get started. Thank you all for putting your names and organizations in the chat. We're so glad you're starting your Thursday morning with us. I'm Kim Schuler, and I'm so excited today to be talking to you about the internship program with the students from UALR. First of all, I just want to remind everyone that staying on today's call, you are giving us your permission to record you, and we will be putting this recording on our ABIN website along with the slides. So if you're interested in any of that information and want to come back and see it, it will be there. Excuse me. I also want to say thank you to Blue Cross Blue Shield for making this program possible through the endowment that they have provided for this program. This is the third year that this program has been happening, and we see continued growth every year. So thank you, Blue Cross Blue Shield, for the opportunity to work on this project. We also want to thank UALR for partnering on this project. UALR has done an amazing job growing this behavioral health integration program, as well as U of A Fayetteville, excuse me, both U of A programs. Want to thank both of them. And then we have 5 different sites represented. And so we're going to be talking with those individual sites today, but I want to thank you all for hosting students. Without you, this program would not be possible. And then I just have to say thank you as well to Caitlin Johnson. Caitlin has done an outstanding job. She has truly been really a cornerstone in this project, and she has been providing lots of hands-on supervision to our MSW students, and also continues and provides some supervision to students that have graduated that continue to have interest in this model. So I want to just give a shout out to everyone because without you all, this wouldn't be possible. And we know that very few people get training on integrated behavioral health in their programming. However, with projects like this, we're able to start training the workforce so that when people leave their internships, they could go to different sites and they could practice integrated behavioral health. They feel confident and prepared and ready to go out and do this in the world. Okay. So let's just do a quick level set and talk about what is integrated behavioral health. And so when I think about integrated behavioral health, I think about whole person care. Behavioral health is an umbrella term. It covers mental health as well as substance misuse. And so we really want to think about this broadly. We've seen more and more growth in the areas of integrated care. We're now hearing a term called integratedness. And basically, that term means as long as we're trying to provide some type of services, and we're screening and we're providing brief interventions in our clinics, that's amazing. There are several levels of integrated care, and today we're really going to be focusing on full integration. And that means we have an embedded behavioral health consultant in a clinic. Another thing that's happening, we know patient-centered medical home programs are happening in Arkansas. And so this is a component of advanced patient-centered medical home. It's important for us to meet the behavioral health needs in the primary care clinic because we know primary care is where people go. All of us at some point are going to primary care. And if we can identify and catch people early, it's really going to be possible for us to provide them the best care, including addressing their mental health care. Here are the different levels of integration that I mentioned. SAMHSA has done a great job looking at what are the 6 levels of integration. We have everything from coordinated care, which is offsite, to fully integrated care. And for the purposes of this program, we are so excited that each of the participating clinics are excited and eager to have a behavioral health consultant fully embedded in their team and working with them every day. So, what happens with this program and how do the students get trained? Well, we start out doing a 2-day boot camp because lots of times when we are getting started, this is their introduction into what is integrated care and what does it consist of. What will I be doing is a common question that we get from the students. And how do we know we're going to be ready? And so we go over what is integrated care. We teach them about the PCBH model. We also talk to them about referrals and warm handoffs. Warm handoffs and curbside consultations are really a hallmark of this model. And that's because when people come in, if they're having acute needs, we want to meet those needs right now in real time today. And we know if we have to send people away without an initial contact, we might lose that contact. We're teaching them brief interventions. This model's typically 20, 30, maybe 40-minute brief interventions. And we also spend a lot of time on risk assessment. We know that risk assessment is an essential part of this. And if we can teach them how to do a thorough suicide risk assessment, that's going to take them a long way. Here's a couple of pictures of the students over the years. We've had fantastic groups, and you could see they're all smiling and eager. We're so grateful, and we're so grateful you're going to get to hear from them today. We are doing weekly supervision with them, and we are also available to them whenever they are in the clinic. And so if they have a need or a call, we're meeting with them. We also do group supervision where we have case presentations so they can have peer-to-peer learning. And that's been really helpful. This way, they're not just hearing from us, but they're learning from each other, especially when they have interesting and challenging cases. It gives us an idea to problem solve and work through some of those challenges. We have online library and resources for them. So they have handouts and can give patients some of the psychoeducation tools that are needed. So we're going to talk to you a little bit about the results from this year. So this year we looked at what language are the primary patients speaking. Primary patients are English speaking. We do have a small percentage of Spanish speaking students and then a small percentage of Marshallese speaking students. So we also took a look at, well, what type of insurance do these patients have? Because that's always something important for us to look at. The majority of the patients that have received the service have been private pay. You can see a breakdown though. Medicaid is a close second. We did not break out the exchange, and so this might be a little skewed. There might be a higher level of patients that were in the exchange that we put in the private bucket. But this is it. You could see in this model as well, uninsured patients have been able to access services. And I think this is really important because especially with the interns, having an intern on site, the interns are there free. They're there 3 days a week. And they're providing these services. And so sometimes what happens is when someone may not have insurance, they might be in between getting their insurance back or their Medicaid back. This is an opportunity for them to receive services and not fall through the cracks while waiting. The majority of the referrals have been we've got chronic health conditions. You could see it's almost evenly broken out. Mood disorders, which depressive disorders are falling in that bucket. And then we've got anxiety, stress, and panic. All of the patients that are being seen are being screened. So we're using measures to track progress. And our students are doing a fantastic job with that. we know that really moving towards measurement-based care is important, because if we aren't measuring, we can't really prove that patients are getting better, and we can't show a decrease in symptoms. We have seen a decrease in symptoms in both the PHQ-9, which is a depression measure, as well as the GAD-7, which is an anxiety measure. And we've seen an overall 18% decrease in both the depression and anxiety. So we're really pleased and we're excited. Students are doing a great job with the interventions, because we're able to see and prove a decrease in symptoms. Okay, so now we are going to move to the sections where we get to hear from the clinic. And we have a clinic site with us today, and we're also going to talk to the students. And we really want to spend time hearing from them what this experience has been like. So we want to spotlight River Valley Medical Wellness. River Valley Medical Wellness is here with us today. We have their very own Dr. Kristen Martin, who is the founder. And you can see their amazing staff. And Dr. Martin, I don't know if you would want to take a minute and tell us a little bit about River Valley and some of the services you offer at River Valley.
Okay, sure. So yes, River Valley Medical Wellness, we originated in Russellville, but have clinics now in Russellville and Hot Springs, and then also have our two mobile health clinics that we take out to rural Arkansas, where we see patients, and then also a lot of them will come to our clinics once we've identified them. We provide an integrated healthcare model where we have primary care, mental health, and addiction medicine all together. And so we really feel like that this approach to whole person care is so important, particularly realizing that a lot of our patients that we get with, I'm board certified in addiction medicine and family practice. So we see a lot of people who may come to us for addiction medicine care, but realize that they have underlying mental health illnesses, or are seeking to get their primary care health taken care of well, with a lot of the chronic diseases, and being able to look at them as a whole person. So we have myself, I have, I think, 5 or 6 nurse practitioners now, mental health providers, an LPEI, Tim Hughes, and then we have 6 peer recovery support specialists that work for our team. And of course, we have our intern, Tessa, who has joined us and provided a wonderful addition to our team.
Awesome. Dr. Martin, thank you. Wow, you guys have grown. And as we can see by the photo, your staff just continues to grow and grow and grow. And now you're expanding with these mobile units. So you don't have just your brick and mortar, but people might see your Armor units anywhere up and down the highway, crossing Arkansas. Well, we just want to first say thank you so much for your willingness to have a student and host one. We know that sometimes starting something new, when we talk to primary care clinics, they're like, well, how is this really going to work? But I have to say, with you, you were totally on board, really excited, ready to start something new and innovative. And so I want to ask you, what has your experience been like working with an MSW student this past year, specifically in this integrated behavioral health model?
Well, it's been wonderful. I really feel like, and I get patient stories every week that they share as far as their experience. First of all, Tess has been fantastic. Very well prepared and supervised. I felt like, and one of the things I say as an owner of a clinic is I not only want to provide quality care, and we're very patient-centered and patient-focused, but also if there's things that we have that we need to improve, because we've been growing so rapidly, and we have some really complex patients that we take on that others will not. And so being able to deal with complexities and issues requires a lot of times us also being able to identify where there's problems or where there's high risk situations that we can't solve unless we know them. And so one of the things I think has been really helpful is we do GAD-7s and PHQ-9s for every patient that comes in. That's always been a part of our care. But our Tessa, our intern, was able to identify, hey, I think sometimes maybe we haven't always flagged or assessed or known maybe when somebody was at higher risk. And so I love it when somebody can not only identify a problem, but help me figure out the solution so that we can even provide better care for our patients. And so that's one of the things that we've been working on is how do we really close the loop and make sure that we're not just screening and or assuming that patients are telling us how they feel. So that's been fantastic. And my patients have absolutely loved, and I have, that I tell them, I have medicines that I can help prescribe and I can talk to them about different things, but being able to have the opportunity to have short interventions where they can work through even what I call bite-sized pieces of their complex problems has been really helpful for them and has really turned the page on some of their what have been chronic conditions or very complex conditions that they felt very overwhelmed with trying to do it all at once. And what I've seen is I've been able to not only not have to increase medication doses, but for a lot of times people have started to realize, I think I've better understand my disease. Now have some skills to work on it and recognize coping mechanisms. And with some of them, it's either we haven't had to prescribe as many medications, or they've been willing, especially with some of our chronic controlled medications, that somebody says, I'm ready. I think I'm ready to decrease that benzodiazepine you've been talking to me about, which to me is yay. So wonderful. But they really have identified that the key component of that has been their work having some true coping mechanisms or things that they've been able to identify with our intern, which is fantastic. It's wonderful. It's something that that I'm glad that they can get a perspective and be able to do some work like that we just sometimes don't have all the clinic time to do, or we're not able to see that perspective from a physician perspective, maybe that Tess has been able to see and work with them on. So, I can talk all day about this, so I'll stop there.
No. We're so appreciative, and we greatly value your opinion and your experience. Let me ask, so it sounds like having a student has really brought value. It sounds like it's brought value to your patients, to providing them some education, even to the workflow process, looking at the screeners. I'm curious, I don't know, one of the things that we hear sometimes from primary care providers is, I'm really hesitant about bringing someone on. I don't want them to slow me down. I don't want them to clog up my workflow. And I don't know if you could speak at all to that, what your experience has been in regards to those.
Sure. And I do understand that. As a matter of fact, this month, right now, I have a resident and a medical student that are training with me. And I will say, when I take on students with care, that it's important. Somebody trained me, right? And so I feel like I need to give back. But the reality is, as a provider, that it does often slow down the process. You have to be committed to the process. With the intern in this capacity, it did the opposite. I have patients that I know that they need more time and attention. And I'll use an example: medication adherence with our mental health patients, or even I have some chronic pain patients or diabetics But a lot of the mental health patients, it's being able to have somebody that can like kind of work through that process, do some motivational interviewing. I know some patients that just really have some serious mental illness that just have difficulty understanding why they need to take their medicines as directed, or just some compliance that I feel like the things that I was saying or trying to work on maybe weren't landing the same, or maybe they're afraid to tell me the things because they're afraid that the physician might be upset. But when I can take them and say, hey, can you come over and I'm gonna have you work with Tessa for a little bit, let's see if we can get some of this figured out. She's been able to do that and get better compliance, better outcomes. And no, if anything, it helped take a load off of me of some areas that I just didn't have the time and capacity, I felt like, to do as good of a job as I wanted to. So no, absolutely not. She's really helped with that workflow. And if I can improve that patient's outcomes, then those future visits also go better, right? We're talking about, we're seeing it and we're talking about, oh, well, this is great progress that you made. And those visits shortened from, 30, 45-minute visits to now we're back to 20 minutes or back to 15, because they're like, you know what, I'm doing great. I think like, I'm following Tessa's homework that she gave me and the things. And so, yeah, it's not only better outcomes, but then those visits become less complex in the future with greater adherence to the treatment plans. So, to me, win-win, right?
Absolutely. Yeah, yeah. No, that's great to hear. That's great to hear, Dr. Martin. And we did not pay you to say.
No.
I'm
As a matter of fact, I was looking, I was like, what are we going to talk about this morning? No, this is genuine. And to say my patients are thrilled. They just want more of her, right?
Absolutely.
The biggest
And,
problem we have is that they say, well, can she just be like my permanent counselor, or what else can we work on with her? So no, great patient feedback, some real successes, and it's helped in our flow. It's helped us identify some things that we wanted to improve. But most importantly, our patients' outcomes are doing better. So, and we've given her some really complex patients that I know when she first started, she was like, is everybody this complex? You know what I mean? So, and not that she wasn't willing to take it on, but just the significance of the diseases that we deal with. Because I say, if you don't ask the questions, you often don't find out the answers, right? And so when we are a practice that actually asks those questions, when we actually screen everybody that comes in the door, then you find a lot of the hidden issues that are out there that, I've been an ER doctor, but it's a lot of times we don't ask questions that we're not ready to treat right then, right? That are chronic conditions. But the same is true in primary care practices, that sometimes we haven't always screened and asked questions for things that we weren't prepared to handle. So then that means people don't get connected with that care they need. So
absolutely. And it sounds like you all are doing an amazing job. You're providing these services to patients. You're meeting them where they are. You're getting them the care they need. Whole person care is such a hallmark of River Valley. I just want to ask Dr. Martin if you could give any advice to someone who is thinking about starting to participate in integrated care. What advice or information would you give to a new site who is thinking, I might consider having a student next year, but I'm a little uncertain?
sure. And ironically, I'm going to give you an answer that we've talked about a year ago, is that whether anything that you're starting that's new, whether it's like when I decided I was going to start doing addiction medicine, or whether it's, hey, I think I'm going to start adding an intern or going into a new area, just start with something. your something may not be the same as my something, right? I really love substance use disorders and helping in that area. And so that's a passion for me. Um, but it may be something as simple as how do you help your patients with anxiety or depression? Or it may be how do I help my patients? I've got all these chronic health conditions and I can't get my diabetic patients to be compliant, you know. Um, Everybody has an area or a portion of their practice that they feel like that they wish that they had greater success with or compliance, or that's more difficult. And I'd say just start with one thing, because then you can build on that one thing. And I think I'm always amazed at really what all the integrated health model can do that I haven't even tapped into yet, because I started with one thing and that one thing is like, whoa. So that's the thing. I think just start with one thing, and that you can just implement it and progress, that it doesn't have to be overwhelming. And being able to do that. And there are different programs, models, ideas that are out there as far as what that thing can be in your area. Is say whether it's mental health or whether it's chronic medical problems. Um, uh, Other chronic medical problems. Sorry. Yeah, I think just start with something. Just be willing to kind of take that dip the toe in and start with something, because even just something as simple as a PHQ-9 that we know is a quality measure we should be doing. Even if you just started with a PHQ-9 for each of your patients that came through, or a subsection, and started there, there's a ton of work that we can do out there. But craft it to be your own. It'll be okay.
Oh, awesome. So I just want to recap. It sounds like you've had a fantastic experience
Yeah.
with your intern this year, that they have brought value. And most important, we hear that patients have responded really well. And it's a meeting, it's helping meet the overall goal, which is whole person care and
Right.
improved health outcomes. And ultimately, that's why we're all here. And so I just have to say thank you, Dr. Martin, for your willingness, for your innovation, and for all the work you do at River Valley. And so now we're gonna turn it over and we're gonna ask the students some questions. And I'm gonna turn it over to Caitlin.
Sure. The way that you're describing starting, Dr. Martin, is very much the same thing that we tell our patients, right? When we're working in integrated health, just bite-sized chunks. We can break it down. So it's the same. We use it across the system, which I think is fun. There's a couple of questions in the comment section for you, Dr. Martin. I know you can't stay on the whole time, so I'm happy to email those over to you if you want to answer them, or if you want to answer them in the chat, just for the interest of time. They may be a little bit more in depth that I'm not sure how much you want to answer that. So whatever you're comfortable with. But Kim, can you go to the next slide for me?
Sorry, I wasn't watching the chat.
It's okay.
There we go.
Okay. And in just a second, I'm going to ask the students to introduce themselves. But I do want to give just a little bit of a shout out to all of them. When we interview these students, it's a pretty, it's not the most intense interview I've ever seen, but it is pretty intimidating for graduate school students, in my opinion. They come on the screen and there's a panel of people there to ask them about this internship, and that's not typically how these placements go. So it's a little bit more competitive than the traditional internship placements in the MSW program. So the not only have they been doing a fantastic job, but they were very brave to even accept the interview and come in and really advocate for themselves and why they thought they would be the best candidate for these internship placements, because they are the social workers on site. You know, all of my supervision is done remotely, and it's very hands-on. It's very in depth. I talk to the students almost every day. They shoot questions that are outside of supervision. They're very curious on how things work. But ultimately, it does take a self-starting student, an independent one that is confident in their ability to practice ethically and ask for help when it's needed. So as we're listening to some of these students, just keep that in the back of your mind, that this internship's really competitive and they have worked their butts off the last 2 semesters. So with that, I'm going to ask the students to introduce themselves and share what clinics they're at. And well, Tessa, you're the first on my screen and they kind of already know where you're at, but please introduce yourself and we'll go to Curtis after.
Sure. I'm Tessa Honeycutt, and obviously I work with Dr. Martin here at River Valley Medical Wellness, specifically in the Hot Springs Clinic. I don't know what all you guys want to know about me, if it's, a fun fact or if it's what we like, but, I live in Arkadelphia. I commute here to Hot Springs. I also get to do a little bit of work with some of the Russellville patients, but my background's in case management. I've done HIV case management. I previously interned at a child advocacy center, so I felt like this was a really good placement for me. I've really enjoyed it, but let me know, Caitlin, if there's anything else I need to add in introduction.
Perfect. That was perfect. Yeah. Thank you.
Okay, I am Curtis Harris Jr. I am at the 12th Street Clinic for UAMS, as well as the Longevity Clinic as well.
Okay, Will's my next one. I see Will on the screen next.
Hello, my name is Will McCoy. I am from Monticello, Arkansas. I'm currently placed in good old Warren, Arkansas, here in Southeast at the Marsh George Clinic. And my first internship was at a psychiatric residential treatment facility for adolescents 11 to 18. And my background is in biology, so this is a bit of a career change for me.
And I'll go next. Hi, I'm Anna Watson, and I'm at North Hills Family Medical Center, which is in North Little Rock, and I commute from Searcy, Arkansas. And then my internship actually last year was with BB Public Schools, but I do have a background in health sciences, and I got my bachelor's in psychology, so I do have like a little bit of familiarity with all of that. So yeah.
So we have an interesting bunch of students that come from all different schools with their undergrads and that. So it's really been interesting to see how, a biology degree has been integrated into this learning, and how Anna has, during supervision, she'll talk about the health psychology that she learned in undergrad. And it just is really interesting to see all of this kind of blended together, because it really does. I mean, it just lends itself, the conversation of multidisciplinary. This takes everybody on the team. It takes multiple perspectives. So I'm really excited to have these students. I'm going to go ahead and start the questions. Just like we talked about, guys, this is whoever feels like they want to answer or has something to contribute to the conversation. We'd love to hear you, but no pressure. Don't worry. So when you were looking at internships, when you started working with Letitia on internships, what motivated you to say, hey, I do want to talk to these people about this behavioral health integration internship? Did it align with your career goals? What interests you about it? Kind of start with that and let us know what was the most exciting to you about this internship. I'm not going to call on people this time, so it's whoever.
Yeah. I think for me, it was a model that I'd never really like seen before, and I really like the component of kind of blending the two together and like looking at the whole person, because that's something I've always valued, especially with like my background. So when I heard about it, I was like, yeah, this is definitely something that like I'm interested in, and I think like it will really help me with my clinical skills and deep dive into more connections with networking and all of that kind of thing. So
Nice.
I'll go next. So in undergrad, I pursued a BS in biology and psychology and a BA in sociology, thinking that I would end up in medical school as a psychiatrist, going into that field. And of course, when I changed to social work, I thought my options were kind of limited. Again, my previous year's internship was at a CAC. That's kind of what I thought social work was going to be. And for my concentration year, I just decided I'm going to do whatever's local. Like, it's not a big deal. I'm just going to pick something that's easy, right? And then last minute, I ended up going to the internship fair, and Caitlin actually wasn't there. So I was talking with her student that was there. And she got to talking with me and was, telling me a little bit about what integrated care looked like. And I was like, that actually is not what I thought social work looked like. And I could expand my knowledge in a field that actually interested me. I could really pull from that biology background. I could do some collaborative care that I really was hoping I would have in a career. And it was just everything that I was looking for. It was all my interests combined in one. It was an opportunity to use a degree that I never thought I would use again, to be honest with you. So I didn't waste that background, so that's nice. And I just saw an opportunity for that to really serve me long term, because I did develop a lot of amazing skills. I've built some really great relationships, and I think this field of integrated care is a great opportunity to continue to learn. And that's my biggest career goal, is to never be stagnant, to be a well-rounded clinician, wherever that might be. So I think that this was just the perfect opportunity, and I had to snag it. And I emailed Letitia at the very last minute and was like, hey, I want to change my priority to be with AVEN. And then I got an interview. So worked out.
We love our psychiatrists, but we're really glad that you decided to do social work. Curtis, I saw you come off mute. Go ahead.
I think for me, the biggest thing that motivated myself was, how does the behavioral health and general health, how do they connect? Just yesterday, I can give the clearest example. I had a patient, and he was not taking his medication at all. And he was more so, it was chronic pains. And he pretty much was like, well, I don't want to take the medication. So I was able to connect these dots of, okay, the reason why your depression is here is because you're not taking this. And once I was able to connect those dots for him, he said, okay, that makes a lot of sense. No one ever told me that.
Mm-hmm.
So now he's like, well, I want to take the medicine, but can I come and see you? Can I come and talk to you? And I said, okay, wow, that works for me. So the motivation for me was, one person at a time, how can we help them? How can we save them? So that's how it worked for me.
Mm-hmm. Good point, Curtis. I think, a lot of times, kind of like what Dr. Martin was talking about, these appointments for the providers go 30 to 40 minutes, and we know that people are double booked and triple booked, and these appointments are really only supposed to be 10 to 15 minutes. So it really, not only as interns, but behavioral health consultants that are terminally licensed, they become schedule extenders. They're able to dig a little bit deeper. And, like you were saying, Curtis, they're able to find some of the, pinpoint where the dysfunction is coming from, and able to rectify it or help the patient fix it. So when they go back in and see their doctor, that appointment is streamlined, and they're seeing faster results, and they're feeling better, right? That's the biggest thing that we want from our patients, is that they're able to function, they feel good, and they feel confident in their healthcare, and they feel like they're the expert on their health, right? Okay, bring up my questions. All right, any more before I move on to the next one? Okay. So, and Curtis already did this, but I'm sure you've got a couple more stories up your sleeve. But could you share a moment or an experience during this internship that had a significant impact on your perspective of integrated care, or just something that was profound that you saw in a patient that made you say, hey, okay, I understand how this model works, and I understand why it's important to continue to do this model in healthcare?
Yeah, so for me, even just this week, I had a patient that a nurse presented me with. It was kind of a warm handoff situation, but the patient called looking for information to be in a detox program, and the first place he thought to call was his primary care provider. And none of on the care team, other than me, like had that kind of knowledge of how to find resources for that. And luckily I was able to reach out to Caitlin, and she set me up right away with a contact. And just that day we were able to get services for our patients. So it just having that really is like a perspective like, wow, this model like actually works. It is something like people want to reach out to their primary care providers first. And when you have behavioral health consultants in the clinic, they're able to just provide that much more of services to patients.
I was going to follow up with you on that, so I'm glad to hear that you were able to connect with him and get that patient services. But you bring up such a good point, Anna, and I've said this a couple times just in my own practice. Is I've never thought about even calling my primary care physician for something like that. Like, but being in the position I was, there was always phone calls about I have no transportation, I have no food in my house, I can't pay for my medications. That was often, right? And I can't get to the pharmacy. So to your point, I mean, it's happening more than we realize. These people are calling their PCPs because they've seen them for 20 years and they're friends. They care about them, and they think, okay, this is somebody that I can come to and ask these questions, but they might not have all the answers. So having someone like you on the team that's able to quickly give those resources that doesn't disrupt the clinic day is super important. So not just the brief intervention, but also the fact that you're there as a resource as well. Very important. Curtis, I did see you come off mute. Go ahead.
I believe too is the fact that just by seeing as far as PHQ scores go down, that's when I became, me personally, when I started seeing GAT7 and PHQ scores going down, that's when I said, okay, this is working. And I also was able to see other doctors start looking at this and saying, wait a minute, you're seeing them every week. And I'm reporting back to doctors and saying, hey, you see this? Now, when they started at a 20, now they're at a 12. And we're 3 weeks in, and they're like, okay, we're on to something. So let's keep it going. So that works.
And to give a little background on Curtis, at the UAMS Fall Street Clinic, it's ran by students. So not only is he seeing his own patients and providing interventions there, he's also doing another important component of BHI, which is education to our providers. And there's been several conversations where he's had to advocate for the profession and really advocate for his patients on how important this person's presenting mental health is affecting how they're treating their diabetes and how they're interacting with their hypertension treatment and how they're interacting with their doctor. So I'm glad you brought that up, Curtis, because that is a very important part, is that we're not just educating our patients. This is also an education for our providers too.
I'll also add, I've had a lot of conversations with my placement doctor following warm handoffs where the doctor will mention things like, oh, wow, this patient really opened up more to you. They told you a lot more information about this presenting problem than what we discussed. And so, it's interesting as well to consider that, oftentimes these are people who might have used this PCP for years and years and years. And so they're very close, but there's some discomfort that comes along with sharing certain aspects of their presenting problems or of their life stressors. And so to be able to provide that supportive, non-judgmental, and just safe environment for them to disclose that information with somebody that doesn't have really any play in their life just reiterated that perspective of value that this model does have. And it does contribute to that whole care that this model is really all about.
It's a great point. Yep.
Can I interject on that? Just to say that is absolutely true. We absolutely hear that. And that's part of one of the things I think is true, that a lot of times, especially in rural communities, that people see their provider, their medical provider at church, at the grocery store. Mm-hmm. And even if they have decades, and particularly when they have decades, they may say, this person, delivered me. And so I don't want them to know I'm feeling this way. And so it's one of the things that we hear a lot, and that while we think as providers, well, I've developed these years of experience and relationship, the fact of the matter is sometimes that is the barrier, because they don't want to disappoint, or they have something that they want to be able to share, talk to somebody about that they, despite the longevity of the relationship, it creates a barrier that they want to talk about something more personal that they feel, I won't say guilt and shame about, but maybe just something that they do, that they need that extra perspective or somebody to talk to. So I love it that you shared that, Will, because that's absolutely true.
For me, it was a very specific encounter that I had that I remember just vividly. Like, that's what hit home for me as to why integrative care was important and how it was supposed to work. So sometime in the fall, I was meeting with this patient. She was referred to me just for, basic generalized anxiety disorder. We were working on some coping skills, and specifically we were working on CBT. And the patient was prescribed, I believe it was Wellbutrin. And so we kind of started this process at the same time. She got prescribed some medication, and then we started doing the actual coping skills together. And about 4 weeks in, she just had this complete meltdown, did not want to come see me. Anxiety was too much. And she was attributing it to like a handout that I had given her. It was very basic, like cognitive restructuring. And so I was confused, but at the same time, I was very overwhelmed. I was like, gosh, I failed this patient. Like, I sent her into this episode. This is all on me. I feel horrible. And so I started talking with her provider, and I was like, she is probably feeling too the effects of her Wellbutrin, full effect right now too. And the more that we talked, the more that we collaborated, we realized like this was not a normal reaction for her, even given her anxiety. Like, this was out of character for her. This was not normal. And this was something to look into further. And so we came up with a strategy together, and she agreed that if I could get her in the clinic that day, do a brief assessment, if I still felt like partially her symptoms were due to adverse effects of the Wellbutrin, that I could schedule her in a brief rapid appointment and she would do a med change. And we did just that. She got in. I felt like some of her symptoms were definitely medically related, but yes, the CBT too, and I'll get to that here in a second. But her provider switched her to Prozac instead, and she still takes it to this day. Wonderful compliance, wonderful patient. And it did well, but at the same time, I also switched my approach because I think the CBT was stressing her out, and we focused more on ACT to cope, and it was just the perfect recipe. So between the med change and the coping skills change, we collaborated, what worked, what didn't work. And actually, not too long ago, this week, Dr. Martin pulled me aside and said, hey, this patient's doing really well, and she just wants to see you and talk to you for a minute. And she did. She is doing so wonderful with the Prozac. She still uses her ACT skills. She is doing just phenomenal. And like Curtis said, we definitely saw a drop in her PHQ-9 and GAD-7 scores just all across the board. She is happy. She is more confident. Her life just in and of itself is just playing out really well for her, and I'm so proud of her. But seeing that come together, I don't think that we would have noticed the gaps in care had we not been in collaboration. Like, she probably wouldn't have gotten that med change. I probably would have just attributed that was my failing too, and I would have carried that guilt with me. So I think it also plays the importance of accountability and competency across providers, across practices, and the importance in coming together in sharing our concerns and sharing our strategies. And that's when that hit home for me, because that was, August when I first met her, and here we are in March, and she's doing phenomenal. So that was my hit home moment for the importance of integrative care.
I know we're all super proud of Tessa on that one, and I remember discussing that with her. And I do want to give her the kudos. She recognized it on her own of like, oh, I think this might be a medication issue. And I think that brings up such an important fact, is that that's an example of advocacy there for our patients, right? As social workers, we are taught to advocate for our patients, and usually we think about like social justice, and we go out and we talk to our representatives and that kind of stuff, and that's that's advocacy, but this is an example of it doing it every day and just taking a quick look at a patient and saying, okay, let's have a conversation about that. Because the traditional medical model, that might have been just kind of written off as, oh, there, maybe we need to increase the medicine. Maybe we need to, it may have went a different way. Should have not had Tessa's view on it. And I saw you come off mute, Dr. Martin.
Yeah, no, I was going to say it is just one of the patients that I saw in Hot Springs this week that had those comments, and she was absolutely elated at her progress, and a person who's wanting to further her career and can focus and be. It really is at a life-changing moment for her too, right? Where if it had continued the way it was going, as a provider, you're exactly right. I might have said, is she really doing her stuff? Is it just she's stressed out with school? There's all those different things that we might calculate and do. But by having Tessa work with her and us work and collaborate together, just making that change, it is like a 180. Yes, she's so happy, so productive. And yeah, she just wanted to know, is Tessie here today so I can say hi? And that's what we love, is that people then also gain a trust in us, that we not only care, but that we're willing to sit and say, you know what, we're the ones that need to make the changes. Let's work with you in that patient-centered approach to find a solution. Because otherwise, too oftentimes people feel like, we hear time and time again, I didn't continue to take medicines. I don't need those. Those don't work for me. Right. And they're not willing to try other options because they weren't heard before. And so now that we've created a relationship, that when other things come up, if they do in the future, we have gained her trust because we've gotten her real results.
Yeah. I was just going to add, one of the things that I think is so amazing about primary care is we have this longitudinal relationship, right? So providers have this longitudinal relationship that really sometimes spans over their life. And I think with this model, we could see improvement, in these 4, 6, 8 weeks. And then when patients start improving, when they come back, there's an opportunity to do a quick check-in, to do some boosters on skills, and you can actually check in with that patient without having to keep them on a caseload for months and months at a time. So I think for me, one of the things I love seeing is a longitudinal relationship, and you all described that so beautifully. She's back, she's asking, she's checking in, and you all are able to meet her where she is and celebrate with her.
Well, I don't know about y'all, but I'm feeling very motivated. So I don't see patients right now, but I'm gonna go out and find someone to therapize because I'm feeling very motivated. Okay, I know we only have a couple more minutes, and I would love to ask this specific question because in this internship, we really try to concentrate on rural areas and underserved areas. So I'm wondering if you guys could share just has there been any challenges that you faced integrating into primary care, or specifically in a clinic maybe that hasn't had one of you before, or in a rural area? What kind of challenges have you faced, maybe talking with your patients about this model or resources or anything like that? What's come up for you?
I'll take this one. I know we only have a few minutes, so I'll try to make it fast. And admittedly, this is something that I probably rehearsed in the shower the most, so I'll try to do it justice. Again, I'm in Southeast Arkansas. We are a desert in so many respects. There are so many there's no resources, almost no resources in our areas. In addition to that, there has never been a social worker in the clinic that I'm in. So that would probably be the number one most challenging part of this internship, is just the program building that has taken place. I've also had a lot of resistance with clients and with staff because they're not used to having social workers there. And we kind of have to get in there and rub elbows and just learn each other and our processes. And I've had a lot of clients say things like, my family thinks to seek mental health treatment makes you weak, or I had a good upbringing, I have all the things I need, I shouldn't need therapy. I think one of the most important things and one of the most valuable things that this particular model allows is for us to just be present in these clinics. And I think that's the first step of normalizing mental health treatment, is just having those discussions, implementing those screeners, catching people who, again, they may not discuss these things with their PCP, and just trying to normalize that. It's been a big challenge, but we're making progress. And through advertisement, through those discussions, there has been some valuable work that has been done.
Thank you. Well, yeah, you bring up such a good point. That this internship does ask a lot out of you as far as your implementation skills and more of a macro mindset. So you're really doing both. You're doing the one-on-one, you're doing the brief interventions and really buffing up those clinical skills, but then you're also having to do a program implementation. And it's difficult even for I mean, Kim and I, who've been doing this a good minute, implementation is difficult. It always is. So because change and growth is painful. It doesn't mean that it's bad, but sometimes growing and changing can be uncomfortable, and that makes people a little resistant, whether it's patients or staff. So I'm so glad that you brought that up. Curtis, I saw you come off mute.
Sure. I think one of the biggest challenges that I had starting off last semester was the fact that certain individuals, they didn't see the value in what we do. They really did not see the value. Me being the competitive person I am, I won't make you a believer, but I will allow the model to make you a believer. Mm-hmm. The proof is in the pudding. And after they started seeing, okay, wait a minute, these clients are getting help that they need. They're explaining more to Curtis than they are to me. Mm-hmm. And now Curtis is coming back and saying, hey, if you do X, Y, and Z, I think this will work out better for them. Mm-hmm. So that works. Another example was when I first got there. I think for maybe 2 weeks, I think it was. Caitlin, I actually spoke to you about this. A lot of clients didn't want to see me because they would say, hey, a social worker is in the other room. We want to, maybe you can go and talk with him. And they, no. We don't want to see him. We don't want to see no social worker. So I came home and I said, okay, how can I fix this? And I went back to them and said, don't call me a social worker. Just call me either a consultant, call me a colleague, mm-hmm. or call me a behavioral health consultant. Mm-hmm. Call me that. So what they did in the clinic, they completely changed the whole policy. Don't call them social workers. On the board, it says behavioral health consultant. As soon as they started doing that, yeah, I talked to him. Yeah, come on. So it worked.
Mm-hmm. Good, great point. I mean, because you can imagine you start crying and the doctor says, well, hold on, let me go get my social worker. That doesn't really ring like I want to, that's something I want to discuss with you. Let me go get a social worker for that. And you're exactly right. This is just somebody on my team. This is somebody who works with me on these types of things. Let me go grab them to talk about it. So, okay. One more question, but Warren had a good point in the chat that I saw is that the health psychology field is very heavy in this conversation, and it's used in every conversation that you have with a patient. And I do want to point out too, as part of your comment, Warren, is this field, everyone, all of our mental health care professionals could work in this field. I've worked with LPCs, actually primarily LPCs in another health system doing integrated health. Our psychologists, this model was built on on psychologists a lot, and then social workers fit in. LMFTs I've worked with. So I know that wasn't necessarily the point of your comment, but I do want to bring up that this is an opportunity for all of our mental health care professionals. Everyone fits into this model as well. Okay, so last question, words of advice. So students or future students watching this or that will watch it later when they're doing the research for this internship, is there any quick words of advice that you would give to them going into this and just how to keep their chin up, because this is a pretty difficult internship and how you've dealt with it?
My biggest thing is one, keep an open mind. Right? You never know what's going to come in. You never know who you're going to work with. So don't have too specific of an expectation as to what your internship is going to look like, because I'm sure all of our experiences are very different based on our setting, population, providers, their backgrounds, etc. But something that I had to keep in mind is you might not see results at first because this is new for everyone. Patients don't come in expecting to see anybody asking them these questions. So it might not be until, spring semester, somebody that you met in August, you're going to see progress with, or they might not want to meet with you until then. So playing the long game, and don't be so hard on yourself if you're not getting bites at first. It takes time. Dr. Martin calls it, fill me in, Dr. Martin. What is it she say? Planting seeds. Yes. The touch points. She calls them touch points. Touch points are important. If you don't see results right away, if you don't have people interacting right away, that's okay. Just play the long game and it'll come.
Good point.
To kind of piggyback off of Tessa, something that Caitlin and I discuss, don't rely on or expect validation from your clients, especially in this model.
Yeah, I had the same kind of challenges too in the beginning, trying to build a caseload and like putting referrals out and kind of not hearing anything back or that kind of thing. So that is challenging, in the beginning, but not letting that get to you. And also another thing is just kind of like embrace the experience as a whole and like take on learning from all the professionals on the care team and like getting their perspective is just really important too, because you are in this position where you are surrounded by so many great people that have, different backgrounds. So that's really exciting to be able to get that.
Absolutely.
I would say learn as much as you can. You were chosen for a reason, so make the best of it.
I agree. Yes. That's what I tell all of you, right? Like, you're here for a reason. We believe in you. Kim, did you want to do this part? I didn't want to interrupt. Okay. We just want to give a quick thank you to all of the clinics that are pictured here. Every single one of these clinics took a leap of faith with us, and they have worked so well with our students, and they have worked well with us. And taking on and implementing BHI and an intern is a big thing at the same time. So just thank you to Dr. George out there in Warren, and Dr. Martin, and UAMS, and of course the schools, and Dr. Lofton, who didn't have a student this year, but has been a very big supporter of this program, has had a student every other year. North Hills, we love our North Hills. There, I'm always over there, always talking to Penny. And then very much thank you to the Blue and You Foundation. That this wouldn't have been possible without your vision and your support as well. So just wanted to say thank you to all of those that have helped us out with this.
Awesome. Yes. Thank you, Caitlin. I know we're at time. Wow, what an amazing job you all are doing. Phenomenal. I am so excited. And I am so excited that we truly are planting the integration seeds all across Arkansas, rural areas, metro areas, and you all are going to be carrying this on with you. Thank you for all you do. Dr. Martin, thank you for being here with us today and sharing your experiences. Caitlin, thank you for all the work you do to make this program a success. And we'll see you all next month. Well, actually, let me give a quick shout out. We do have our Behavioral Health Integration Conference on April 8th. This is going to be at the St. Vincent Center for Health Education. It is free. It will be a full day, including 7 CEUs, and our focus will just be behavioral health integration. So come out and join us. We'll be back in May, and we will have Landmark Recovery. They'll be talking to us about their program and trauma and addiction. So we can't wait to see you. Have a wonderful spring day, and we'll be in touch soon. Take care.